Well, good morning and welcome, everyone. My name is Jamie Haverl, and I'm the Executive Director at the Iowa Healthy Estate Initiative. We are thrilled to have you joining us today for our Economic Impact of Obesity on Employers webinar presented by Lilly. In 2011, the Iowa Healthy Estate Initiative embarked on a journey rooted in the belief that good health enhances the lives of individuals and bolsters our state economy. As we convene today, it's crucial that we explore an issue that not only impacts individuals and families, but also resonates profoundly throughout our workplaces and the wider economy. Our focus today is on obesity, a complex health condition that permeates every facet of our society. Obesity is defined as a medical condition characterized by an excessive accumulation of body fat, which can detrimentally affect one's health. According to a 2023 State of Obesity report by the Trust for America's Health, Iowa ranks as the 11th most obese state in the nation, with a notable 37.4%, or 3 out of 8 adults living with obesity. This alarming statistic underscores the urgency of our discussion today. Over the past decade, obesity rates have surged, outpacing even the other prevalence of other chronic health conditions. Obesity is a complex condition that cannot be reduced to the matter of individual choice or personal willpower alone. It is deeply intertwined with economic, health, and environmental influences that demand our attention. Addressing obesity necessitates a multi-sector approach that addresses the influences and disparities that contribute to obesity. So as we embark on this journey of addressing obesity, it's imperative that we educate ourselves about what obesity truly entails and what it does not. Understanding its profound impact on individuals living with the condition, as well as the ripple effects on employers and the broader economy is pivotal. Last fall, we initiated a vital conversation through our inaugural roundtable to delve into the ramifications of obesity in our state. Today, we're poised to further this dialogue by delving specifically into its impact on employers. However, our quest for knowledge and awareness does not conclude here. Rather, it's an ongoing endeavor that will continue to unfold across 2 additional events this year and beyond. So mark your calendars for April 17th, when we'll convene for our Workplace Wellbeing Conference. There, a distinguished panel of experts will illuminate strategies for addressing obesity in the workplace, offering invaluable insights and solutions. You can scan the QR code on the screen to access more information, including how to register for the conference. And in September, we'll reconvene for our second Obesity Roundtable to further our conversation on opportunities to collaborate around strategies to reduce the risk for obesity and advance equitable obesity care for those living with the disease. Additional details on the roundtable will be shared later this summer. So before I introduce our speaker for today's webinar, I have a couple of housekeeping items. All attendees are muted, and we ask that if you have a question, please use the Q&A function that can be found on the Zoom toolbar. We will address the questions at the end of today's presentation, and we'll do our best to get to all of the questions that are submitted. Please note that the chat function is not enabled for today's webinar. This webinar is being recorded. A link to the recording will be provided in a follow-up email that will be sent to all of our attendees. And if you should encounter technical difficulties, please log off and re-log back in using the same link that was sent to you via email. So now it is my pleasure to introduce today's speaker, Tim Dall. Tim serves as the Executive Director of Life Sciences at GlobalData. A trained health economist, Tim brings more than 20 years of experience conducting research and policy analysis in the areas of health economics and outcomes, health workforce, healthcare delivery, and disease cost and prevention. Tim earned his Master of Science in Labor Economics at the University of Wisconsin-Madison and his Bachelor's of Science in Economics from Utah State University. Welcome, Tim.
Thank you. So the work that I'm going to present is based on a series of studies that we've done with the funding from Eli Lilly and Company, looking at the economics of obesity and the value of treatment from different perspectives. Today, I'll be talking about the economics of obesity from the perspective of employers, and other studies that we've done have looked at it from the perspective of the states. And at this link below, you can see, you can access these reports, one of which is for Iowa. advance the slides here. Oh, there we go. Okay. So when we look at something as complex as obesity, we look at it using different skill sets and tools that we have available to us. We first use health concepts around epidemiology, health behavior, health outcomes, healthcare service use and costs, and health equity to look at it from that perspective, but also economic concepts, looking at labor market dynamics and workforce planning and scarcity and choice and opportunity cost and skills such as cost benefit analysis. And we bring all this together to look at this complex condition because there's medical costs involved and there's productivity losses and other implications. Part of the reason for doing this is that when employers look at the literature on obesity, much of it is not really geared towards employers. It might have little snippets about productivity or healthcare costs, but often they're national in scope and they can be older studies. Sometimes they're written by researchers for researchers and written in a way that's difficult to kind of interpret when trying to influence policy decisions. And so what we try to do is make this very accessible to employers. We start by looking at the prevalence of obesity and overweight among the workforce. And I would note that when we talk about the economics of excess weight, about 80% of the costs that I'll be presenting are associated with obesity, and about 20% are associated with overweight. So once we estimate the prevalence of obesity among the workforce, we look at the implications for healthcare costs, disability payments, workers' compensation payments, the productivity implications for absenteeism and what we refer to as presenteeism, which is you show up for work even though you're not feeling well and your productivity is lower. We also look at some concepts that we were not able to quantify in monetary terms, but we discuss in our report, those being workforce resilience, turnover, and hiring. And there's quite a bit of literature on topics such as bias and discrimination based on body size and physical appearance. And in terms of workforce resilience, when we look at the COVID-19 pandemic, there's quite a bit of literature that shows that obesity and the comorbid conditions of obesity, such as diabetes and heart disease, were linked to severity of COVID as well as probability of hospitalization and mortality risk. And so there are these workforce implications that we discuss in our report. Many of these are kind of occupation and industry specific, but they don't show up in our numbers because just there's lack of data to quantify the implications. And once we look at these risks and cost implications, we report in our study the US totals, and then for 7 major economic studies, we do a little bit more of an in-depth study on those 7 industries. We present information per employee with obesity and per employee with overweight. And then we model a hypothetical organization with 10,000 employees plus their dependents. And we say, for this hypothetical organization, what would be the implications of excess body weight? The idea being that if your organization has 20,000 employees, you can take those numbers and double them. If you've got 5,000 employees, you can take your numbers and cut them in half. And that will at least give you a ballpark estimate for what your annual costs are for obesity. I would also note that many of these costs might be jointly borne by the employer and the employee. For example, if a person's productivity is consistently lower because of their health reasons, or if they are consistently missing work because of absenteeism because of their health reasons, that might be reflected in lower pay or fewer promotions. And so employees bear this burden, and also the employer bears part of that burden in terms of lost productivity. And some of those are very difficult to quantify. So when I present these numbers, just note that not all of them are necessarily borne by the employer, but some of those are shared with the employee. When we look at the prevalence of overweight and obesity, it varies quite a bit by industry. And this is based on analysis of the National Health Interview Survey with national data. And in that, this is all self-reported data where people self-report their height and weight. And the literature has shown that self-reported height and weight tend to result in underestimates of the prevalence of obesity relative to studies where a clinician actually weighs a person. And so that's one thing just to take into consideration. Also, the body mass index, or BMI, is an imperfect proxy for if a person has obesity or overweight. And an example would be in some industries that are very physically demanding, a worker might have more muscle mass content and bone density, and they might just be heavier. And so body mass index is taken into account how heavy a person is, and not necessarily the portion of their weight that is from fat. But so those are things to take with just that caveat. When we look across industries, the highest prevalence of obesity that we estimate is among the mining industry at 38%. And the lowest prevalence is among the professional, scientific, and technical services industry at 22%. Part of the differences here is just due to demographics, that in some industries, the population tends to be a little bit older and more, there can be racial and ethnic diversity, and that can play into the prevalence rate. But overall, across all industries, we estimate that about 30% of workers have obesity and about 34% have overweight. And these numbers are a few percentage points lower than what we see in the general population. At a very high level, across the different industries that we model with 158 million individuals, this is the non-farm civilian population. So it actually excludes like farmers and others for which we have a lack of information, a lack of data. But we estimate that the total economic cost of excess weight to the nation is a little over $425 billion in 2023. Of that, about $78 billion is associated with overweight, and about $347.5 billion is associated with obesity. When we do a little bit deeper dive into this, the main contributing cost to this, the biggest cost, is higher medical costs associated with obesity. That's about 27% of this total cost, and this is about $115 billion per year. The next highest kind of category would be presenteeism associated with obesity at $113.8 billion, followed by absenteeism associated with obesity, presenteeism associated with overweight, medical costs associated with overweight, workers' compensation costs, disability payments, and then a small sliver is associated with workers' compensation costs associated with obesity. And then when we look at this across industries, we can see that among the government sector, it's about $85.3 billion associated with excess body weight, and it's smaller for other industries. The main driver is that the government sector is very large in terms of number of people. The education and health services sector also very large in terms of number of people. But there are other factors that play into this. In government, they tended to have a higher prevalence of obesity compared to, say, professional services industries, in part because of the demographics, and it's skewed towards a slightly older workforce. And in government, they also had higher costs associated with absenteeism and presenteeism and medical costs. So it was higher on a per person basis, but also there are more people in that industry sector, and so that drives up some of the numbers in that sector. So when we look at this from the perspective of an individual person, we estimate that a person with obesity incurs about $1,514 per year more in medical costs compared to a healthy weight person. The numbers in the literature vary. This is within the range of what we see in the literature. Some estimates range as high as twice our number, and some are half of our number. Most of those look at the costs for a commercially insured population or just the entire population, and these are specifically costs for people who are working. From a recent publication by some researcher, Cindy et al., we take their estimate that higher disability costs for short-term and long-term disability average about $664 per year per person with obesity, and that higher injury worker compensation costs average about $112 per person with obesity. Now, when we look at the actual raw data, this is very skewed to a small number of people with very high costs during that year and some people with fewer costs during that year, but these are our averages. We also look at the literature and do our own analysis of absenteeism and presenteeism. Shindy and all, the ones that did the disability and the workers' compensation costs, they also report higher estimates of work-related absenteeism. And they have a very large database of employees that they use to come up with their estimates. But in the literature, it indicates that if you look at the cost of presenteeism and absenteeism and only cost it out based on a person's salary, that actually underestimates the implications for employers, because if a person's missing work or their productivity is lower, it can have implications on productivity among their team members, quality control, management costs, and so on. And so we use a multiplier effect to scale those up to what we think is the estimate for employees. And these, again, are on an annual basis. So when you combine these numbers together, our estimate is that at the national level, a person with obesity incurs costs of close to $6,500 per year, and a person with overweight has costs of around $1,244 per year. And again, these costs are jointly borne by the employer and the employee in a variety of reasons. And then for adult dependents, we don't have as much information on their medical costs per year, because in the data, we can't really identify the adult dependent of an employee who is not also in the workforce. And so we use as a proxy for their additional healthcare costs what we estimate for the employees. These numbers might be conservative, but we estimate that for adult employee with obesity, it's about $1,514 per year in higher medical costs. And for an adult dependent with overweight, it's about $380 in higher medical costs per year. As mentioned, we then create a hypothetical organization with 10,000 employees and estimates from the literature and from our own analysis of, on average, how many dependents would be covered, along with these employees, take-up rates for medical insurance, and what the cost would be for this hypothetical organization with 10,000 employees. And at the high end, in the government sector, we estimate that they're spending about $36.7 million per year in costs associated with excess body weight. Again, the majority of this is associated with obesity. Some of it is with overweight. And then at the professional and services sector, at the lower end, it's about $19.4 million per year. Again, this is a sector with a younger workforce that tends to have a lower prevalence of obesity. And so at the national level, we estimate that it's about 26.9 million, so kind of in the middle of these numbers here. And we've got the breakdown on workers' compensation, disability, absenteeism, presenteeism associated with overweight and obesity, and then total medical costs. And that sums up to the 26.9 million at the national level. Now, national numbers can skew things in a number of ways when we apply it to an employer within a particular state. For example, across states, there's differences in demographics, prevalence of obesity. There's differences in the cost of healthcare, the cost of living, and the implications for wages and benefits. And in Iowa, we estimate that it's about 27.2 million per year for this hypothetical employer with 10,000 employees. And the cost range from a low in Colorado of about 22.7 million to a high of 37.6 million in Hawaii. And again, there's a variety of factors that play into this. But we can see that Iowa is, kind of similar to its surrounding states. So when we look at this hypothetical employer with 10,000 employees, and then we adapt it to Iowa, accounting for differences between Iowa and the national average in the obesity prevalence. Obesity is about 9% higher in Iowa compared to the national average. Overweight is about 1% lower than the national average. Cost of living is about 10% lower in Iowa compared to the national average. Healthcare costs in Iowa are almost the same as the national average, about 1% higher. And so when we estimate these numbers, Iowa comes in at almost the same as the national average, at slightly over 1% higher than the national average. And so this is how we come up with the estimate of 27.2 million for this hypothetical employer in Iowa versus a national average of 26.9 million. And you can see the breakdown here for the different components with, again, healthcare costs, presenteeism, absenteeism associated with obesity being the three largest components. So then the next question is, well, what can we do about it? We understand there's this high burden, and this burden is being incurred year after year, regardless of, if you don't treat it, this is what your cost will be, about $6,500 per person with obesity. So what we do is for each of the major industries and for the US workforce as a whole, we created a representative sample of the demographics of that workforce and their dependents, where we took information from various government sources that we could create this profile that had their demographics, their various biometrics like their body weight and their blood pressure levels and cholesterol levels and hemoglobin A1C levels, and whether or not they had certain conditions like diabetes and heart disease and so on. And for each person in this population, we ran a simulation with this model that we have, this disease prevention and treatment microsimulation model, where we can simulate year after year as they age what will happen to their risk for disease and various economic outcomes. And so each year as we age, usually our body weight goes up, and as we age and our body weight goes up, our blood pressure goes up, and our cholesterol levels goes up, and so our risk for heart disease goes up, and diabetes goes up. And so we simulate this over a period of 10 years. And then we introduce an intervention, and we model different weight loss scenarios of if we could get treatment for obesity and lose 5% body weight, 10%, 15, 20, and 25% body weight, what would be the implications year after year over the next decade? And part of the reason we did this year over year is that some employers and industries will have different time horizons. We recognize that for some employers, they have turnover and employees might only stay for a few years. In other industries and employers, your employees might be lifetime employees and stay for an extended number of years. But the reason for choosing these different weight loss treatment scenarios to model is that there are multiple options to address obesity. For many people, lifestyle and behavioral intervention, which often results in weight loss in the 5 to 8% range, is enough to move them out of the obesity category and substantially reduce their risk for onset and severity of disease. And then when we look at some of the older obesity treatment medications that are on the market, these are often achieving 10% weight loss in clinical trials and real-world evidence. Then we've got the newer GLP-1 medications to treat obesity that are on the market. And in clinical trials, these are achieving 15 to 20% or more among the population. And then we've got metabolic and bariatric surgery, which can achieve 25% or higher in terms of weight loss. And so that was the justification for running these different scenarios to show the options. But one thing to understand is that when we look at the body mass the body mass index distribution for commercially insured adults with obesity, it's a very skewed distribution. And you can see that a lot of people with obesity are sitting right at a BMI of 30, 31, 32. A BMI of 30 is the cutoff for obesity, and below 30, from 25 to 30, that's the range for overweight. And so what we have here is a substantial number of the population that with just a small amount of weight loss can move out of that obesity category. And for others, it would take a substantial amount of weight loss to move them out of obesity. And so when we take that BMI distribution, what we estimate is that among the commercially insured population, about a quarter of those workers with weight loss of 5% or less can move out of the obesity category, and close to 22% of the population with obesity among the commercially insured population, they would require 5 to 10% weight loss to move them out of obesity. And so what we're saying here is that about 50%, almost half of the people with obesity with 10% weight loss or less, we can move them out of the obesity category. And this is very achievable with lifestyle intervention. And for many people, that plus these older obesity medications will move them out of obesity. And then we have about half of the population with obesity where we need something more aggressive, whether that is the newer medications with demonstrated higher weight loss or bariatric surgery. I would note that we're also working on a study that's still a few months away from being published on what the actual treatment cost would be to treat a population, recognizing that many people might be eligible for surgery, but elect not to use it, or they might be eligible for medication, but for whatever reason, it's not effective for them, or they choose not to use it. And so we're working on a study to actually come up with what the cost would be. These results right here show that over a 5-year period, if we could lose 5, 10, 15, 20, or 25% weight loss, what would be the implications for some of the more prevalent chronic conditions? And so if we look at type 2 diabetes, which is like this dark green line, with a 5% weight loss, we would reduce the onset of type 2 diabetes by about 5%. Under more aggressive weight loss scenarios, at 25% weight loss, we could reduce the onset of type 2 diabetes by close to 40% among this population over a 5-year period. And recognizing that when we model the 25% weight loss, many of the individuals don't need that full 25%. They need just 5, 10, 15, 20% to move them out of the obesity category and substantially reduce their risk for onset of type 2 diabetes. When we look at the entire population with obesity, these are the annual numbers over 10 years. And we can see that in the first year, the weight loss, it ranges from about $430 per person under the 5% weight loss scenario to $810 to $20 per year under the 20 to 25% weight loss scenarios. There's a little bit of variability in the simulations, and so sometimes you get these slight rounding differences in these numbers. And as we move to 5 years, we're now looking at between $2,200 and almost $5,000 in terms of medical savings. And then over 10 years, we're looking at around $5,300 under the 5% weight loss scenario to about $13,500 under the 25% weight loss scenario. Recognize that this is for the entire population with obesity, and even under the 25% weight loss scenario, a large portion of the people need less than 25% weight loss to achieve those benefits. And this is just looking at the medical savings. It does not take into account the benefits in terms of reduced absenteeism and presenteeism and other costs to employers like disability and workers' compensation payments. And these numbers vary by industry. This is looking at the 5-year aggregate medical savings due to weight loss under the 5% and 25% scenarios, and it varies by industry based on a variety of factors, including the demographics of that workforce, the current and future predicted disease prevalence, healthcare costs, and so on. And then when we look at a population with class 3 obesity, this would be people with a BMI of 40 or higher. the numbers are quite a bit larger than if you just look at the population with obesity overall. And so under the 25% weight loss, we're looking at about almost 1,300 in the first year, almost 8,000 cumulative over 5 years, and about 22,000 cumulative over 10 years. And these are national numbers. And so from what we showed before, in Iowa, the cost of care is just slightly higher. So it'd be just 1% or 2% higher in terms of the numbers specific to Iowa. So with this, we have a set of recommendations for employers. And in these recommendations, we tried to be somewhat general. We didn't want to be prescriptive because employers, their characteristics can all differ in terms of, obesity in their workforce and the resources they have available to them. But our first recommendation is just to treat obesity as you would any other disease, like diabetes or heart disease, and to provide comprehensive insurance coverage for obesity and wellness programs, just at parity with other chronic diseases. Also, to upgrade and implement or incent use of wellness programs. We know that many companies do have wellness programs. There's always more that can be done. And in our report, for example, we refer to a diabetes prevention program that's offered at the work site that showed an improvement in body weight. So there are wellness programs that can be done and adapted to your workforce. Also, to foster a culture of support and inclusion. Sometimes this is just making sure that there's healthy food options. If you have a cafeteria or other resources in your at your place of employment, some have gym memberships. It can be things as simple as trying to change the culture so that if instead of going to a conference room for a meeting, like with a one-on-one with a colleague, you might just go for a walk instead. And then to provide education and resources. Often this involves partnering with your insurance program and other providers, just to make sure that employees have the resources that they need. The idea being that when an employee and their dependents sit down with their healthcare provider to talk about how they can treat their obesity, that they have all the tools available to them to address their obesity. Online, we have fact sheets that are available. We've got a national fact sheet. We've got a fact sheet per 10,000 employees. We've got a fact sheet per employee with obesity and overweight. And if these can be of use to you in your jobs and in your discussions with management about the implications of obesity and the value of treatment, these are the resources available to you. There's also copies of PowerPoint slides online if those are of use to you, as well as our report. We have some industry-specific fact sheets that are available. And again, these are for the 7 major industries where we took that deeper dive. And then also online, we have the state studies. And I want to just talk about a few key findings from those state studies that have implications for employers that were not included in our employer report, but they are in the state reports. So one is that when we look at the data on earnings, we find that women in the workforce with obesity are earning 9% less than women in the workforce with healthy weight on average. And this is controlling for demographics and other factors like smoking status. And these findings are actually consistent with other published studies in the US and overseas. And this would be 9% less for women with obesity. For men, we did not find any obesity impact on earnings, just for women. And this lower earnings, of course, just adds to the disparities that we see in earnings between men and women, and here between women with obesity compared to women with healthy weight. We also looked at labor force participation patterns in the National Health Interview Survey, and we combined multiple years of data to get sufficient data to get some robust numbers. And we find that over the 2017 to 2021 timeframe, that women with obesity, their odds of being in the workforce declined by about 20% compared to women with healthy weight. And men with obesity, their odds of being in the workforce declined by 7% relative to men with healthy weight. And so there's a few interesting things. First of all, the impact of obesity on labor force participation is about 3 times greater for women than it is for men. We don't fully understand the reasons why they're out of the workforce. It could be most likely is a combination of things. There could be biases and discrimination in hiring and layoffs. There are health reasons that people might voluntarily choose not to be in the workforce. But again, this just adds to additional disparities, economic disparities that we see. When the most recent National Health Interview Survey data became available in 2022, we dropped the latest data, 2017, and re-estimated our numbers. And what we found was that the obesity impact on labor force participation for men did not change, but for women, it actually declined. And as we looked into year-by-year trends, what we found was that as the unemployment rate drops, the obesity impact on labor force participation also fell. And in the literature, the Federal Reserve Board had done a study on discrimination based on race, and they found something similar, that when the unemployment rate falls, that the amount of discrimination and hiring and layoffs also falls. And so it's just something interesting that I think would be great for future study. So another factor is that each year, about 500,000 people in the US die prematurely for an obesity-related cause. They're not dying from the obesity specifically, but they're dying from the heart disease and the diabetes and the strokes and the heart attacks that can be linked back to them having obesity. And this, when we look at the demographics of these individuals, about half of these individuals that die prematurely would still be in the workforce today. Many are in their 50s and 60s. They would still be in the workforce today. And so the takeaway from this is that because of obesity, there is a smaller labor force and pool of people for employers to employ. And these are not taken into account in our employer study, but are in our state study. So when we just kind of take away the summary point here, each worker with obesity, there's about a cost of close to $6,500 per year. And if we don't treat their obesity, this is a cost that will continue year after year. And so there's a cost of doing nothing. And so that's kind of the main takeaway point. So with that, I'll turn it back to you, Jamie, and open it up for questions.
Well, thanks, Tim, so much for sharing the report with us this morning. So now we're going to take a few minutes to answer questions from the audience. So as a reminder, please enter your questions using the Q&A function that can be found on your Zoom toolbar. So our first question we have is, with Iowa having such high rates of obesity, is there any legislation being considered to give tax incentives to employers to help fund wellness programs? We offer a lifestyle savings account, but it's taxable.
Yeah, that's a good question. And I'm probably not the best person equipped to answer that question. Maybe we can just take a note of that and find out from whoever the expert is and respond. But a few things to take into consideration are, to the extent that government is allowing certain healthcare costs and premiums to be pre-tax or tax deductible, it would make sense from an economic perspective to make those programs, to offer those kind of tax incentives.
Thanks, Tim. And we'll definitely make sure we follow up. Excuse me. Another question we have here is, as employers are thinking about short and long-term costs when making healthcare coverage decisions, can you comment generally on how investing in better care of chronic diseases like obesity may have short and long-term benefit?
Sure. So there's the savings implications, right? And we recognize that with turnover, employers concerned that they might invest in their employee who then leaves, and they incur a cost without reaping the full benefits over time. I think some of the research that we're seeing, it's very preliminary still, but is that for employers that are offering access to obesity treatment, it because many of these treatments require that you remain on the medication over time, that it helps to engender reduced turnover, that employees, when they get a benefit like that from their employer, they're less likely to leave. So it can reduce turnover, in addition to the medical savings and the improvements in productivity. Within an industry, many benefits in a healthcare plan are mandated from the government because of the same issue, especially around prevention. If you provide prevention, it benefits everybody. And if that employee leaves to go to another employer and you replace it with somebody else, well, that person's already gotten, that preventive care through their insurance, through their employer. And so if you do something on an industry or a national basis, then it benefits everyone. But those are, I guess, considerations that an employer needs to take into account as they look at treatment options. Is to what extent can this be a tool to help improve retention among our workforce?
Thanks, Tim. Another question we have here, and
I would also note, there are concerns about cost of treatment, and over time, costs will continue to come down as there's increased competition and generics become available. And so, I don't think we want to forego the current population with obesity and treating them to wait for the future for what might come, a decade or two in the future. But just note that costs will be coming down over time as generics become available and there's increased competition in the treatment community.
Thanks, Tim. Another question, and you may not be able to answer this, so if not, just let me know and we can make sure that we find someone that can. So is it possible to only allow coverage of these drugs for a very, very specific group of individuals, high BMI, another comorbidity, or if we turn on the ability to get these drugs, are we at the mercy of the doctors?
Good question. So right now, people with obesity, with diabetes have access to these newer GLP-1 medications. And just recently in the news, a number of insurance companies have announced that people with cardiovascular disease and obesity, they will not be covered. In terms of the resources that a firm has, obviously we would advocate for everyone with obesity being treated. But there are some people that would benefit more than others. And so those are maybe calculations that an employer might take into consideration. But I'll leave it at that because I'm not a medical expert.
Thanks. Another question we have is, have you seen any data yet on how the new weight loss drugs are impacting obesity costs versus the additional coverage costs for employers?
Yeah. So this is something that we're working on for our study that'll be forthcoming in 2 or 3 months. One thing, though, is that when you sometimes read articles in the newspaper about the cost of coverage, it's very misleading. For example, they might say, we've got 75 million people in the US with obesity, and it's going to cost $1,000 to $1,500 per month per person. And the total cost exceeds like the gross domestic product of the country, whatever. And those are misleading for a few reasons. First of all, as I showed before, not everybody needs the most powerful medications. Many people would be fine with lifestyle counseling and intervention, or some of the older anti-obesity medications that might get you, the 10% weight loss. So those are things to consider. And then in addition, even though the list price is what's often quoted in the media, the discount price is often substantially less than that. And it'll vary by insurer, but your discounts could very well be 30 or 40% relative to list price. It's not public information, so I don't know the exact answers. But one analogy I would use is if you look at metformin used to help treat hemoglobin A1C levels and prevent diabetes, as you look at antihypertensive medications and statins to treat cholesterol. When these first came on the market, we were having the same conversation. So many adults need these medications. How can we afford it? and now the price is, I mean, it's just dollars, so no one really even complains about the cost now. It's just part of treatment. So I think this calculus will continue to change over time.
Thank you. And another question we have here is, all of the data is really citing weight using BMI and body weight, not body fat percentage, which is linked to chronic disease. To lose weight for the scale to go down is not an accurate marker. Decreasing body fat percentage, maintaining bone density, and increasing lean body mass through lifting weights and doing exercise with intensity will prevent chronic disease. Has any study looked at this?
So first of all, it is well understood that body mass index is an imperfect measure, especially for an individual. When we look at it at a population level, though, BMI is highly correlated with onset of diabetes and heart disease and severity of conditions and early mortality and higher healthcare costs. But for a specific individual, that might not be the case, which is, again, why we recommend that at a population level, people have access to treatment. But on an individual level, when a person meets with his or her healthcare provider, they can develop a plan, a treatment plan for that individual specific to their needs. Now, it is recognized that there are different ways to lose weight, and for medication alone, when there's rapid weight loss and a change of a person's nutritional intake, that can have implications for bone density and muscle mass. And so, well, first of all, any kind of treatment should be supplemented with lifestyle counseling of how people should, change their physical activity levels and their diet, eating more nutrition, intense food. So that's well documented. There are national gym chains that are now trying to incorporate a weight training along with obesity treatment. So there's a recognition of that. I haven't really looked in the literature for clinical trials on that, but people are aware of it, and there's kind of real world evidence that's starting to become available.
Thanks, Tim. I guess our last question we'll have before we wrap it up is, it really seems like economics is an important factor in decision-making on modernizing obesity care, but there's other factors too. And these might include important topics like health equity, employee resilience, and retention. So how does an economist think about these topics in decision-making?
Yeah, those are all good points. And beyond that, there's the personal stories. Often when we present our economic results, like in in-person meetings, it's often preceded by a person with obesity telling their story. And their story might be something like, I want to play with my children on the playground, but I physically can't keep up with my young children. Or it might be stories like, my husband has, or my spouse has diabetes, and they can get access to these medications, but I can't get access to these medications until I get diabetes. And so, these can be very heartrending stories. And that obviously has implications for quality of life and so on. I think as an economist, what we can do is we can present the numbers. For example, we found several ways in which obesity discriminates more against women than against men. Well, it's not the obesity discrimination, but you know what I mean. That women with obesity have lower earnings compared to women with healthy weight, where we don't see that for men. Women with obesity have 3 times the labor force impact that we see for men. And then our studies, we didn't have sufficient data to look at these implications by race ethnicity, but we do know that obesity prevalence is higher among certain populations, particularly the Black and Hispanic populations. And so to the extent that there are these health and bias/discrimination implications, it would be disproportionate among those populations, those minority populations that have higher prevalence of obesity. Also, people with lower earnings have higher rates of obesity. And so sometimes these factors can accumulate in terms of lower education and obesity, makes it even harder for that person economically. So as an economist, we just put out the numbers and draw attention to them, and then hopefully policymakers can use that information in their decision making.
Well, thanks, Tim, for really providing the latest, I guess, research regarding the economic impact of obesity on employers. And, I think it's important as just educating ourselves to better understand that the economic impacts and just the impacts in general of those who live with obesity on a day-to-day basis as well. So as I stated at the beginning of our our webinar today, our goal really is to create that awareness of obesity and learn about strategies for how we can reduce the risk of obesity, improve that equitable access to obesity care for those who live with the condition. So thanks again to Lilly for sponsoring today's webinar. An email with a link to the webinar along with a copy of the slides will be hitting your inbox next week. So this concludes today's webinar, and thanks again for joining, and I hope you all have a great day.
Thank you.